Hi, everyone. The mic's on. Okay, thanks for having me. Yeah, as was mentioned in the introduction, I'm an assistant professor of health informatics, and I'm here to present my lab's work on emerging research in cognitive sensory mobility impairments. And so what makes our lab's work unique? A number of things. We deal with very challenging populations. So for example, we've done research with people who have epilepsy, people with pacemakers. So I'm not sure if you're aware, but these are contraindicated on a lot of the commercially available headsets. We also deal with very difficult settings at times. So we're starting research in the intensive care unit, in specialized dentistry. So we really try and push the boundaries, although it's very exciting to hear about the other research that others are doing here today. And I'm hoping that you leave with, so I'm going to talk about a number of different projects in 4 areas, and what we're hoping is that you leave with a greater understanding of the successes we've had, a lot of the challenges we face in these different settings, and importantly, differences we can make to the design of the current interventions, as well as the way we evaluate them, so that the healthcare system in general can see value and it can get adopted, and we can move a little bit beyond research and more into meaningful use and long-term adoption. There's no need really to talk about healthcare. Usually I tweak the background of my introduction, but everyone here knows everyone knows what virtual reality is. So I'm just going to reflect on the fact that it has a background in aviation and the military, and so it's really used to replicate difficult and dangerous environments. And in healthcare, it's been mostly used for the same purposes. So we look at skills training or surgical planning, exposure to environments that could cause anxiety, or clinic placements, for example, for nursing students. A lot of patients get to see their environment before, like preoperatively, to see if it's, to increase familiarity and reduce anxiety around that. Exposure therapy has been used widely. There's been mention of some empathy building. In virtual reality, I'm a little bit skeptical about perhaps reducing the entire experience to something that is just within technology. However, I can accept that it might be an additive tool to help others understand someone's lived experience. And there's some movement to screening and diagnostic tools, both within the use in VR and behaviors and changes of behaviors within VR, but also replicating more ecologically valid scenarios. And I might have a chance to talk about some of these as we go on. So this is what I call my amuse-bouche slide, where I describe or I try and lay out a lot of the projects that the prescribing VR lab does. We basically design, implement, and evaluate virtual reality interventions across the spectrum of care, from acute to community settings. Here you'll see that most of them that are with a green border have to do with cognitive impairment and older adults. The yellow ones have to do with sensory impairments. Red has to do a lot with mobility, and purple is one that I've just added in for fun, which is mental health, but with a special population. And it doesn't really take a keen design eye to see that there's a little bit of a gap there around 2020. I know that we weren't meant to ask questions, so I'm just going to rhetorically ask if anyone knows something that has impacted people's research during 2020, and I will guess that you haven't guessed what happened to me, but it was my personal little pandemic that happened, and thankfully I was able to recover and continue research with a lot of the help from my lab, including Dr. Saryazdi, who's right over there. So, okay, I said I would cover different areas: cognitive, sensory, mobility, and mental health, emerging research in these areas. Some of this stuff has been done already, so what is unique? It's really the challenging populations, like I mentioned, things like people with epilepsy, and so, or people who have more severe cognitive impairment. So really, I'm hoping to talk about challenging populations, the different kinds of design implementations we had across healthcare settings, and so what is unique and what do we need to change about our evaluation moving forward so that, again, this can go beyond research into actual implementation. So let's start. I'm going to start with the first area, cognitive impairment. It's where most of the research of the lab has taken place. I'm going to start, so this started back in 2017. It was really, there hadn't been much research, especially in older adults, let alone people living with dementia, and so we thought we would run a feasibility study looking if we could expose frail older adults to wearing these mobile headsets. I'll say that the background behind this, COVID has a silver lining. We can all understand now, 2 years later, what social interaction and going outside means for a person's well-being and health. And we're recovered, and we're all here in person in sunny California. Okay, I'm coming from Toronto, Canada, wearing a summer dress, hoping that it would be sunny, but no. So we understand the difficulty, but this is people's current real experience, is that they do not have the social supports, they do not have the financial supports, they live in Canada, they can't go outside during winter. There are many issues preventing people from going outside, and yet we know that it has a lot of benefits. Now, at the same time, people living with dementia often have something called behavior and psychological symptoms, and certain presentations of these symptoms are very difficult for family caregivers, and unfortunately result in what we would call earlier institutionalization than would be normal. And even when individuals are in long-term care, presenting with these symptoms has negative healthcare effects, both for the individual, but also for their families and for their caregivers, professional caregivers, that is. So it's all around an unfortunate situation that does not have a good solution. I've been faced many times with clinicians coming to me saying, I do not want to sedate my patients anymore. This hastens decline, it has no benefit. Similarly, restraining individuals is not ethically acceptable. So we're going to try something new. And this is really where this research was born. Can we use other kinds of therapy and see that it would be effective? And so we're a little bit boring from music therapy, aromatherapy, touch therapy. There was this discussion, and I'll bring it up again, about nature walks and the benefits of being outside in nature. And so our idea was really, can we do forest bathing 2.0 and expose people to natural environments that will deliver at least partial benefit and hopefully manage some of their symptoms, overall positive effects. So we started with a feasibility trial. Really, I got a very small grant, and I presented at a conference before launching the study. And so many institutions were excited about this that we ended up getting 4 sites when we had only had budgeted for 1. But there was extreme enthusiasm, and here we were looking at safety and feasibility and maybe trends to well-being. So that had an overwhelmingly positive response. Again, we had a very inclusion criteria was pretty open. We had mild through severe, but mostly mildly cognitive impairment. And from that, we got additional funding to run more trials with this patient population. So VR Squared was a partnership with Pearly Health, which is a veterans healthcare center in Canada. And so we were looking now at targeted triggers that would cause behavioral issues in these participants. So these were already moderate to severe people living with dementia in a long-term care setting where we knew that they would be triggered by bandage changes or by going to the washroom, sometimes merely pulling a curtain, but they had documented behavioral issues. So we thought, can we target these sessions, provide VR before, calm them down, and see if it has an impact. So that was the first. What was unique about this study was that there were multiple exposures. So previous to that, it was very much a one-time exposure and seeing how people reacted. So we had 88 sessions. And also what was notable about this trial was that we worked very closely with the recreational therapists in the center who administer the therapy. So it was not research assistants anymore, but it was actual clinicians, and we wanted to get their feedback on what it meant for workload and psychologically what it meant for them. And we found out a lot of interesting hesitations that they had towards the technology that we're hoping to overcome in future studies. Pretty much concurrently, we got funding to run a randomized control trial, and it's my understanding that this is still the largest randomized control trial in an acute care setting with people who are admitted for alternate reasons but have dementia. We did intend to have a sample size of 200 participants. COVID really cut this one short. We stopped in 2020. But the idea was that we would have individuals who were admitted to acute care randomized to have the standard or to get VR therapy. And again, they received it once every 3 days. And we looked very much at important hospital metrics here. Again, we're trying to move a little bit more to providing the evidence that healthcare would accept in order to provide this more formally, at least within Canada. That is the process required. And so we had interesting outcomes. So we were looking at aggressive behaviors specifically, as well as length of stay, falls, quality of life, medication use. The only metric that but it had a statistical significant impact, was on aggressive behavior based on the neuropsychiatric index and also some other nursing notes findings. So overall, if I were to combine what we understood from the research in this area, there were a couple of other small trials that I'm not going to mention, is that it's safe. There were no real adverse events across spectrums of physical mobility, cognitive impairment. People tolerated this. There was very little simulator sickness. We did vet we vetted all the films that we showed for particular criteria, but that was not a concern. There were generally good outcomes, both qualitatively and quantitatively, but we do have issues with feasibility about introducing this in an acute care setting. I just currently don't think it's feasible. People, there's no time for clinicians. There's no resources in the hospital. There's the difficulty of hygiene. There's the difficulty of it still being accepted as a non-pharmacological therapy in a hospital. If they're not going to introduce like iPods with music, they're not going to introduce VR therapy in hospitals. But regardless, really, it might actually be better placed in the community. Why? Because it actions on aggressivity. And so if we can get people when they're in their homes to calm down, then maybe we can manage the relationship again earlier from institutionalization. And so this leads us to a study which was covered in detail by Dr. Saryazdi, so I won't go, I'll just speak in high level to it, but it was introducing VR in the home. If it's not the first time, it's one of the first studies where we looked at family caregivers providing the care. Another unique thing about this study is that we were looking at communication in addition to just symptoms and behaviors. And importantly, we wanted to start comparing it to quote unquote more familiar technology, a VR like a tablet that had VR films on it. So very comparable, the exact same films that you would have on a tablet, to seeing, is there so much added benefit that it's worth the added challenge of the VR headset? I think I have a short clip, but I'll just speed through.
Give you a pat.
Most of you might have been here at the previous talk. As a caregiver,
must look pretty real then.
With dementia,
They all do.
he's enjoying some scenes. Okay.
Oh. Be friendly.
And here he is conducting an orchestra. We have permission to share these films.
Conducting an orchestra.
Okay. So one of the ways we want to look to evaluate, again, I was mentioning that it's not just introducing this technology, but how are we going to evaluate it so that we can claim there is benefit? So we looked at mood. There were 41 sessions of VR and tablet, and we used a tool called Observing Reactions in Virtual Reality, which we created earlier. It's a validated measure, so we had 2 observers rate this. And what we found, both with the VR and the tablet, no surprise, there's a whole lot more positive reflection than there are negative. We also coded for reminiscence. So it's looking good, but it's kind of looking like a tie between VR and tablet still. But what we could get from this, and I believe, another point we were looking at is, the novelty effect. Everyone's like, oh, you see VR once and then does it get boring? So we divided between the first and second weeks of exposure in each of these, and we actually didn't see a difference. So there didn't seem to be a novelty effect, and if anything, relaxation went up in the second week of use of both technologies, which I think has to do with just getting familiar with the technology, and so it's not so cumbersome to use it. So overall, these results were good. What else can we say? We can say we ran a systems usability scale also with individuals. VR failed in its score. However, this did not prevent any of the dyad participants from using the technology throughout the study. So I'm not going to go in detail again, Dr. Saryazdi did in this study, but I think there's a lot we can learn to improve the at-home use of these tools. And I'm going to go over some of these design principles at the end. But basically, it has a place here, it has some benefit, and so another thing we should look at again is diversity of content and how we can start customizing this so that it's personally meaningful to an extent. It doesn't have to be exactly one's experience. So this is what I'm going to mention about VR in cognition with older adults. I'm now going to switch to VR with sensory health. Now I'll say that, and this was mentioned, hearing loss is the #1 risk factor for developing dementia. However, vision still is our primary sense. I'll have a quick show of hands of who woke up today and used their eyes to come to this room. Yes, those who don't have their hand up are looking at their phone with their eyes and not looking at me, but that's okay. So vision is very important for connecting with the social world. It's important for ambulating, it's important for getting around, it's important for cooking. It's basically what's keeping us independent. And so I work a lot. I mean, in Canada, there isn't that much of a focus on low vision rehabilitation. I'm not entirely sure what the situation is in the US, but I work in collaboration with vision experts, Dr. Reber and ophthalmologists, some of whom are the founders of low vision in Canada, to develop a therapeutic stimulation. So we employ something called a multiple object tracking paradigm, where an individual, and I have a clip to show you quickly, basically there's a couple of balls in front of you, one shines, highlights yellow, and then goes red, and then they move in 3D space, and you're meant to track this. And then after 20 seconds, the scene stops, and it's among distractors, and you select which ball you think highlighted yellow. And then based on the speed and the accuracy of your selection, it automatically updates, the system automatically updates. And there's a couple of these training tools that have only been able to be produced in clinic prior, so this is really making a more equitable argument for providing therapy remotely through a commercial VR headset. So we've run a couple of trials, and we're currently running trials. The therapy is administered at home, the data is transferred through Wi-Fi and analyzed at our lab. They come in 3 times through this 6-week protocol. So there's standardized ophthalmology tests to check their changes in contrast and vision and visual perception. And there's also questions about activities of daily living. I want to stress this because a lot of the ophthalmology tests are just, I really don't feel like they accurately affect changes in people's lives. So a lot of them are seeing one eye in isolation or aren't combined with hearing, which is how we normally interpret stimuli, and they don't reflect changes in, for example, benefits of reading or confidence in crossing the street, which is really what limits someone's ability to age in place. So we're moving more towards doing that. There were already 2 case reports published on hemianopsia patients that had exceptionally good results having done this therapy protocol, and we're currently running pilot studies in pediatric oncology group as well as age-related macular degeneration. And I mentioned this is really inspiring a new set of screening and diagnostic tools that are more ecologically valid and, again, able to send off to a larger population. So I think we do have a quick clip of this stimulation, which is called Revision. So here we're logging in to the app. There's 2 versions of it. The first one, first they take, they respond to VRISE to determine their simulator sickness ahead of time, or their level, their potential level, and they do it after as well. So here you have a number of balls in your view. One shines blue, then disappears, and then they start moving. There's also sound associated with it. I'm not sure if you can hear it here. So you can track it both visually and auditory. And based on, for example, if we have patients that have certain visual perception or vision issues, we can adapt where the balls are to be in their area. Okay, so here. And then we can increase in complexity. This is a very busy intersection of downtown Toronto. So it increases with distraction. So the speed can increase, the fog can increase. All of these decisions are made in the lab by but are updated. Okay, so I spoke a little bit about cognitive impairment, a little bit about sensory impairment, both which impact mobility. I'm now going to bring up another emerging area of research of the lab. And so here we're looking at providing treatment for phantom limb pain, which is different from residual limb pain. 80% of people who have amputations have phantom limb pain, and there isn't, again, a good solution to manage this kind of pain. So we're looking both at incorporating traditional mirror therapy in VR, which there are, I think, 2 articles currently published on that in virtual reality, but we also want to take it a step further. There's something called telescoping. So this is the notion that the further the perception of the amputated arm, or the closer it is rather to the core of your body, the less pain one feels. And so we're looking to create a scenario where, using augmented reality, in fact, in this case, if possible, to have 10 participants with upper limb amputations who have their intact arm mirrored onto their amputated stub, and then play around with both the size of the hand and the distance from their bodies, and see over time if this impacts their level of pain. There's some ideas of incorporating physical therapy into this. Of course, this is further in personalized medicine, in natural settings at home. So this is really a little bit more of an exploratory area, but it will be, yeah, I think we're very enthusiastic. We've got grants both from War Amps and from the Canadian Institute for Health Research in Canada. So there really is a need to find, again, a solution, which currently only pharmacological interventions are administered to this population. Okay, so the 4th area of emerging research is mental health. Anxiety and exposure therapy is nothing new to virtual reality, but putting it in the context of people with epilepsy is. So this study was started by a student of mine who actually has epilepsy and came to me and stated something which then we found in the literature, which is sometimes that the anxiety surrounding the condition is more debilitating than the condition itself. And so what we were thinking of doing is creating scenarios that cause anxiety particular to this population, which both have social fears, but also it's the physical danger, for example, having a seizure and hitting hard surfaces. So there's physical dangers of seizures. There's the aspect of safety with the photosensitivity that has been traditionally contraindicated on headsets, however unsubstantiated more recently. So there's some unique considerations with this population, and we wanted to create graded exposure therapy. So about, I'd say now, a year and a half ago, we started a 3-phase pilot study. I'm happy to say that we started with VR1, as was described in how one does VR research. And so we first sought to engage people with lived experience, people both who have epilepsy themselves, the clinicians that care for these individuals, as well as family caregivers, to describe scenarios that cause anxiety in people with epilepsy that is specific to their seizures. And so we sent out, in collaboration with Epilepsy Toronto, a survey, and we got a lot of feedback with individuals both describing scenes in detail that cause them anxiety, as well as validating scenarios that we had suggested. Public transportation, for example, is one that causes anxiety, and unfortunately is one that a lot of people with epilepsy have to take because they have their driver's license revoked. Things like social events where either you know individuals or you don't know individuals. It depends on your area. Sometimes you feel more comfortable when you're surrounded by individuals who would know how to react should you have a seizure. Other times, for example, you feel very uncomfortable being incontinent in front of people you know, which happens frequently when you have a seizure. So it's very individual. So we ran this and we got some results, and then throughout the past 6 months, we created 360 films with 3 different scenarios. 2 in public, so public transportation as well as a busy mall, and 1 at a private party scenario. Each of these 3 scenarios had 7 different graded exposures, and now we're in what we would call phase 2. We have a feasibility trial with 4 individuals that have epilepsy that are testing these videos. This is, I will also say, is in collaboration with epileptologists at the main epilepsy center in Toronto at Toronto Western. So we're not doing this without expert clinician as well as clinical psychologists that deal particularly with people with epilepsy. And so our goal is, once we've completed the feasibility trial with these 4 individuals, that we would launch this. We're now submitting to ethics a larger trial in the epilepsy monitoring unit. This will be very unique because when individuals are in the epilepsy monitoring unit, so there's a huge wait generally for people who have epilepsy to get to this stage. They stay there for 2 to 4 weeks, and And basically, they're trying to get seizures induced. That's the point of the epilepsy monitoring unit, so then they could see what the triggers are, and then doctors could suggest a certain kind of therapy. So they're hooked onto EEG ratings, they have all the vitals that one would normally have within a hospital, and in addition, we're asking that they're going to wear the VR headset from time to time. We're gonna have a control group that is exposed to just normal relaxing VR scenarios versus a group that's gonna have graded exposure therapy as it was decided by them and a therapist that would be most appropriate. So for that, I think there will be both very interesting outcomes for anxiety related for this clinical population, but just in general, monitoring brain activity while in a headset. Okay, so taking all of this, I suppose, I don't know if it's worth, this is one of the subway scenes. It's now exported in equitangular view. It's not worth seeing, but if anyone's interested, we have demos of these videos on the website, so you can see one of each of the scenarios. Okay, so VRX in healthcare, what is next? What have we learned from merging research in these different patient populations and different settings? Are we ready? I mean, this is a slide I like sharing, and I like joking with this about my 3-year-old son. Which one of these things is not like the other? You know, why did the evolution of controls for VR headsets end up in something that looks like Star Wars, you know, taser? It's really not appropriate for a lot of older adults, for example, who are used to controllers looking like this. I would say I've had a lot of conversations with older adults who say, well, why don't we just use hand gestures, which is possible now in some VR, but it's problematic for people who have arthritis, and it's generally problematic for people with cognitive disabilities who still can't grasp a lot of the navigation. So what is my recommendation? I'm happy to see that this is a lot of what's happening also at the demo booths, is to have a secondary device control. Let's just remove the complexity of the VR headset and have everything controlled by a secondary device. And that's what we've done with this VRX at Home pilot, which was highly successful. And moving forward with all my different clinical trials, I am having things controlled from a secondary device. In terms of content and customization, and this kind of goes across the board, we need more diverse content. There needs to be a subject of interest. So, you know, this forest bathing is not what people wanted to do from home. They wanted a little more action, which now makes a lot of sense intuitively. Perhaps, you know, nurses who are overwhelmed and burnt out want to relax at a nature scene, but people who are understimulated all day don't just want to watch the grass grow. They want to do bucket list things. Things have to be more interactive, game-based, customized interaction has always resulted in greater participation and success, so that's something important. And cooperative and social VR, as was just mentioned in the previous talk. There needs to be another person present. They don't have to be physically co-located. That's the benefit of VR. But I do think that VR should, in the future, be more and more a social experience rather than I'm going to put a headset on and you know, ignore this individual. So to that end, we started creating games. Again, we're co-designing games with, for example, older adults that meet their needs. Things like having, you know, the taser or the sensor from the controller constantly beaming, so there's no selection requirement. It just hits a ball when it touches it. New ways of evaluating. So this is a snapshot of an older version of Observer where we're looking at both positive, negative, and reminiscence, so that there's kind of standardization for populations that have difficulty communicating their experience in VR. And it's important, obviously, to capture qualitative aspects. We're looking at, you know, what do head positions in VR mean? A lot of times when I talk to non-VR audiences, they don't know what yaw, pitch, and roll is. And I often say that it's yes, no, and my dog's like, what are you talking about? Kind of tilt. But there is this idea that when the head tilts higher up, it's more about positive emotions. There, again, hasn't been that much research on this, so that would be a good avenue. We're also working to build in different sensors, EEG ratings within the headset, so we can get objective readings from different patient populations. So but this is still quite cumbersome and difficult to administer in a clinical setting and in the home setting. So just some quick takeaways. Where's the future of VR? I mean, things aren't really that complicated, but it's a lot of hard work. So it's both high tech and high touch. We need to marry these things. We need to really engage real users. We need to visit them in their actual environments to help identify their needs and solve for that rather than just play around with technology and see where it sticks. And notably, we need easier navigation, more diverse content, and new ways to evaluate success. And so I'm really happy to see that there's a lot of work from different individuals trying to help people age in place. There's no other condition that is universal other than aging, really. We are all aging. And if you look a little bit closer, here are technologists also working on trying to balance the resources in healthcare for this reason. And so it's a nice thing that I don't do this work alone. Of course, there's lots of individuals that help me, as well as our funders over here. And I just wanted to say that usually the best way to run these talks is to talk less and hear more, but we weren't allowed to ask questions. So please come up to me after the talk. Let's connect. I really enjoy collaborating and starting new projects. So that's our website. And yeah, thank you very much.